I recently went on a tear about the use of the word juvenile. And it just sort of bubbled up in me one day, and I was standing in front of a crowd, kind of like this, and asked everyone in the room to tell me what their juvenile was doing that day. And people were. I said, so if we don't get up and call our children juveniles, why are we calling other people's children juveniles? Are they less children because they're involved in a system often not of their own choice, not of their own making? I mean, is this something that we can do something about? And it was caught by the local paper, and the program I was presenting at didn't get a good review, but that statement got a good review. So I'm immensely happy at that. And so when invited to talk about my favorite thing, in the context of a whole other discipline, usually I'm standing in front of a crowd of mental health providers and DCS workers and public health officials who are kind of here with it, but not really on the ground working directly with people that are being impacted day after day. I don't work directly in the juvenile justice system. I'm sort of a peripheral support person to that system. And we make the best of it as we can in terms of aiming for reform. So today I'm going to talk about the program that I run through my Center for Health and Justice Involved Youth. And I'm glad you picked up on the fact that I didn't call it the Center for Mental Health and Justice Involved Youth, although mental health and mental illness are a significant part of the challenges that are faced by the kids in the system. The reality is we're talking about health, overall health and well-being as the basis for everything else that we do that is good and productive and looks like thriving, engaged with life, thinking of a future for children. So you're my help with the slides. You've already heard I have no disclosures, financial disclosures or otherwise. That's a permanent part of my slide deck now because as president-elect of the APA, every time I open my mouth, people assume I'm speaking on their behalf. So I want to make it clear this has no APA connection. Next, please. I love to start with something that matters to me. I mean, I know I'm talking to you, but it matters to me that people before me that I love and value their words have said things that have meaning in the context of what we're talking about tonight. And I can't think of a better quote than this from Frederick Douglass when we're talking about kids in the juvenile justice system. These are children. And if we don't take care to do well by them as children, what we will have are adults who aren't prepared for the adult world. So let's put a little of the investment into them as children and make better adults out of that. Next slide. Also like to start with the understanding that this is not Dr. Stewart's anecdotal inference about things that she suspects may have some accuracy and fact. This is science-based stuff. The first person that sort of captured this in a way that was translatable, if you will, to people in the community who needed to understand this was David Satcher when he was Surgeon General. He issued the first series of reports on mental health, never been done by a Surgeon General. He followed up with reports that he issued on children's mental health, on violence as a public health issue, and a variety of other things that matter in the communities where I trained and now work. And so I want people to understand this is not just me making things up because I had one experience with one child or family that resulted in me thinking a certain way. This is stuff that we can go back into the science. And this is now, I guess, almost 20 years old. There's a whole new body of science now around children, specifically in the juvenile justice system, who have mental health challenges and who are victims of trauma, abuse, and other adverse childhood events. Next slide. And then there's always a need, because there is always someone in the audience who wants to know, well, what percent of kids are actually impacted by this? Take a look at this. 65 to 70% have at least one diagnosable mental illness. And we're not talking about mild anxiety or the traditional ODD, ADD, continuum. We're talking about major depression, major psychotic disorders, bipolar disorder, suicidal ideation and attempts, and a variety of other things. So at least one, that's 2/3 of the kids in the system have at least one diagnosable. 1/3, another 1/3 have diagnosed learning disabilities. Almost half function below their academic grade level. And look at a whopping 70%. And again, this is 10-year-old data. 70% have been exposed to a traumatic event. That's a lot of pain and suffering in children. And that's the vulnerability that we encounter in children who are in that system. Next slide. It also helps that the baseball cap makes it look a little like a child. This is a picture of our juvenile court. Is that not a beautiful building where you would like to be on charges that may or may not be relevant to anything that's ever mattered in your life? I have, chills every time I walk in that building. The people are by and large very nice, but that looks institutional. That looks correctional. That looks like a place I don't want to be, and no one should want to be, but that's what it is. And we have one of the oldest in the state. Our juvenile court is one of the oldest in the state. Has had its share of problems. We're now under a DOJ settlement agreement around the way kids were being treated, and the settlement agreement is up in another year or so. And everyone's excited about the fact that the feds will be out of there. We've actually asked the current administration to relieve us of the oppressive federal government early, and thank God, and I say this with no intent to be disrespectful to anyone in the audience, but thank God Jeff Sessions got distracted by some other things because he might have ruled to get the feds out of there before it was time. Next slide, please. Okay, so my center, the Center for Health and Justice Involved Youth. I was telling Consuelo the story earlier. It came about as the result of the convergence of some things. There were politicians who had an idea of something they'd like to tackle, i.e. juvenile justice reform. They had no idea what to do though. And then there was a university that needed to be more reflective around how to interact with the surrounding community, which is by and large mistrusting of the university because of some past history, but also unresponsive to the needs of the surrounding community. And so they were looking for a way to, as my dean said, face outward to the community as opposed to be insulated and removed. And there was, in fact, that whole DOJ, juvenile justice, looking to see what's going on. So there was this convergence of things. And they got together, 3 people got together, the judge, a state legislator, and the university dean, and said, we should do something in the area of juvenile justice, but we don't know what. So let's find somebody who might be able to tell us. And they hired a consultant who happened to be a friend of mine who went looking for me and found me, and the rest, as they say, is history. But here's when they said, what would you like your center to do? Here's what I told them. This is the cleaned up version. The earlier version was a 3-legged stool that did services, specialized services training, and community-based research. So this is the kind of cleaned up version ready for publication of what we do. And you can see we look at how you coordinate long-term reforming a system, because I like to be at the center of the activity. I'm a control freak. I admit it. It's public knowledge. Anyone who knows me will tell you. I like being in charge because I know I can get done what I want to do that way without anyone getting in my way. And then you got the service research training piece. You've got evidence-based interventions specific for the juvenile justice population and programs that emphasize trauma, because that's where we are in the juvenile justice world. And then that are developmentally and gender appropriate, because if you don't remember that children have developmental challenges, whether they're in the system or residing in your home and out of the system, and that there are differences gender-wise between what kids experience growing up and how that affects their trajectory into or keeping them out of the system. If you don't take all that into account as you're looking at policy and funding decisions, then you're pushing the older up the hill with no hope of ever making the top. So that's what I articulated to them in some earlier version, and they bought it. And so my center was established. I think there's a bit of, next slide, I think there's a bit of P.T. Barnum in me, and I'm okay with that. The goals that I established were knowing my community. I needed to balance what I believed to be significant and important around youth development. I needed to marry that with a design that incorporated a personal accountability strategy that worked for the kids in my community, and that community's ability to help them make those strategies work. And I had to always remember that at the bottom of all of this, I needed to let the people who are in charge of protect and serve know that there would always be a public safety component factored into everything that we did. Because otherwise I lose the battle of funding, policy change, reform in any way, because at the bottom of this, we all want to reside in a safe community. As our district attorney often says, Miss Smith doesn't hate little Johnny, but every time he breaks into her house, she gets mad at me because he's back on the street because people like you say he's been traumatized and he doesn't need to be locked up. So I don't need to have that battle with law enforcement, district attorneys, and judges all the time. I need to just factor in how do I build a framework that ensures that public safety is always on the table. And so what we did was we looked at how can we coordinate all of those child serving agencies. The work of a child is school. So schools have to be present. Children in the justice system are by default part of the child welfare system, so they had to be at the table. Our health department actually collects the data on the children in the community around suicide, health status, and some other things, so they had to be at the table. And then there were a variety of mental health providers and substance abuse providers and community groups like Boys and Girls Clubs and a whole host of other people that I'll show you on another slide that needed to be around. And we were fortunate that I'd had an experience managing a grant for a wraparound approach. So I was able to sell the community that I had already worked with around this on how we would fold that successful model into what I was proposing they join me on. I've got a knack, apparently, of convincing people that if you've worked with me before and it's been good working with me, this time it's going to be even better. And people buy it, so it works. And the good news is it's not just a sales job. I really fundamentally believe in what I do. And if I start down a path to doing something, I'm pretty committed to seeing it through. And people now know that. It also helps, just so you know, that I'm a native Memphian. And being from the community has gotten me into more places where other people can't get into, and bought me some credibility without me having to do things initially that other people don't have. I mean, people can say to me, "You're so-and-so's little sister, right?" "Yeah." "Mm-hmm. And you went to," "Yep, that was me." "Oh, I remember when you were a little girl." And there's nothing wrong with being remembered as a little girl if it gets you in the door for the mayor to take a meeting, or for the state legislator to come to your community and host a town hall so that you can talk about ACEs. There ain't nothing wrong with them remembering. I'll even bring out the picture of me as a little girl and add it to the presentation, just for a little ambiance. The fact that we would develop, design, or use targeted interventions that met the criteria of strengths-based, youth-guided, and family-driven, because that's the system of care approach that we wanted to use. And that there would be a balanced and restorative justice component. Because remember, public safety has to always be at the table. So there has to be some understanding of consequence for behavior in the child. Next slide. This is a fun slide. This is the brain of a child, an adolescent. And I have a few extra copies of this that I'll leave with you, but it's available in New Yorker Magazine 2008. I finally put the reference because people kept asking me. But if you look at this, here's the guy down here, probably a teacher, trying to talk about the teen brain. But look at this brain. I think I'm so clever. I know I multitask because I've got all of this stuff, but I'm really not accomplishing anything. I've got these ideas about school and grades, but I've really got a learning disability because I'm doing drugs or drinking or hanging out with the wrong crowd. I never sleep, so I'm sleep deprived. My focus really is on my music or my creative, spoken word stuff. And I'm quite impulsive because I have an underdeveloped, frontal lobe. So I think something and I do it. I don't think consequence. This is the adolescent brain. Anybody see their own child in this brain? I have yet to be in an audience presenting this and not have people say, oh, you know my child or my grandchild. This is the part of the brain that says, you asked me to take out the trash 2 days ago? I don't remember that. I'm supposed to clean up my room. I'm studying. That's what's going on. And look at all these little dangly wires and kids kind of gleefully. This is the brain of the children that we're talking about. I like to think, and I don't have children, so excuse me, I like to think that any child with this brain is lucky they're not in juvenile justice. Because these are the kinds of things that lead to bad choices and poor decisions that wind up for one bad decision, making the rest of your life a living hell. So, next slide. Here's what's going on. This is the direct link from that brain you just saw into the justice system. Lacking the ability to self-regulate when things are emotionally charged. You piss me off, I get mad, I fire off on you, I accidentally break your nose or knock you over the side and you crack your skull on the sidewalk, or I'm playing with a gun and I'm doing this and it goes off. That's what that is. Very sensitive to external influences. We all know about peer pressure and how significant it can be in putting you on the wrong path. And then the lack of a frontal lobe means you really just can't make good decisions. You have no super ego functioning that says, that sounds good, but really driving the car, hanging out of the side, dragging your hand along the road is not a good idea. Or jumping between two cars because it seems like fun, even though I'm sober, is not a good idea. That's the limited ability to make good decisions. Next slide. And so people who think that because I'm acting like an adult, I must be treated like an adult, have come to learn that harsher sentences do not impact significantly the rate of reoffense and recidivism or support public safety. And remember, public safety is always on the menu. So if it's not helping public safety and it's not reducing the rates of reoffending, why are we treating adolescents who commit crime the same way we treat adults? Why are we trying them as adults? And the treatment programs that have been demonstrated to be most effective actually are outside of the structured secure facility setting. They're based on developmental knowledge, implemented to fidelity, and they've been the ones that lower cost and result in tremendous effectiveness in the recidivism and reduction of crime. Next slide. So I talked about some of the people who've been at the table with me from the beginning, and this is just a starting list. Obviously the court, the school, we have a relationship with our law school, University of Memphis Law School, and the School of Social Work around some health policy and some practices, changing some practices. The Memphis Crime Commission, I don't know if there's an equivalent here, they're a nonprofit independent organization that was created for the purpose of maintaining public safety at the table, but they've taken on this larger than life, we're going to reduce juvenile crime by creating all of these programs that aren't really sound, and I've worked with them and I'm still working with them, but they're primarily a law enforcement focused group, and that's not my thing. Then the state departments of mental health and children's services, our local mental health providers, and our health department have been critical to the work that we're doing at the center. Next slide. This is moving us along into the discussion of adverse childhood events, which is kind of at the base of what we do and how we target our work. Everybody's heard of ACEs, I hope, or most of you have heard of ACEs. And so this pyramid is not unfamiliar. There is the triggering event as a child that children are exposed to, that is the adverse childhood experience or a series of things. And that can be abuse, assault, abandonment, neglect, chronic trauma, chronic illness, living with someone with chronic illness. There are a whole host of domains where we measure adverse childhood experiences.
And what happens though is that serves as the base, and then the result is you have some level of impairment developmentally that impacts you in at least these three spheres. You develop some behaviors possibly because of your impairments, which leads to disease, disability, and social problems like incarceration, and ultimately in an early death. So what begins here results in something untoward happening there, which is the continuum of ACEs. And I'll talk a little bit more about that in a moment. Next slide. When I realized that for once I wouldn't be talking to a primary psychiatry group, I thought, well, why should maternal and child health care about ACEs? Well, obviously, duh. We're talking about a population of adults and children, maternal, child, who have been exposed to the kinds of things that ACEs means. We're particularly talking about emotional, physical, sexual abuse, domestic violence. In today's environment, we have to add sex trafficking, sexual violence, and reproductive coercion. We still have challenges around HIV/AIDS and substance use disorders and the sequelae of those things. I myself have had my own experience as an adult child giving care to an elder, and that produces its own series of traumatic experiences way beyond childhood, because even as adult children, we are still children to our parents. And so the notion that you can only get ACEs exposure when you're a young child is, now that I have been through it, now I'm a big advocate for ACEs can happen all the time, anytime. And then for the children that are seen in a maternal child health arena, we're talking about looking at kids at their well child visits to measure the impact of anything that's going on around them on their development, failure to thrive, and of course school performance. And I'm particularly interested these days in truancy, because we've got a major problem with that. But I'm also challenging these diagnoses as possibly more linked to trauma than they are to actual ADD, ODD, and other things that our kids are getting labeled at and treated for, when in fact we may be missing the trauma picture that's contributing to all of this. And so we're failing to treat them adequately because we're relying on some old standards. Next slide. And then I'm a big proponent of mandated screenings for mothers and children for gender-specific interventions and interventions in special settings, because whether it's the OBGYN or if it's someone who's getting treatment at the VA, or it's a mental health substance abuse provider, or the school health clinic, there are specific things that each of those settings can offer to a child and their parent that have to do with the setting and what they're able to do and their funding streams and how you, being in the public sector all of my professional life, I have long ago learned to do more with less and to make lemonade out of lemons. And so every time there's an opportunity to gather additional funding to support a population that needs a particular service by using that specialty service to fund and support that, I'm big on collaboration. Next slide. This is just a tragic slide that I think brings it home. On the left, you've got a healthy brain. And on the right, you've got a brain of a child, an adolescent who was abused. And for those who know this stuff, all of these red hot areas are signs of activity, and you see less activity here in these areas, diminished activity in general. But this is the result of the changing, actual physical changes in the brain as a result of a child experiencing trauma. When I'm talking in community groups, neighborhood watch groups, or community neighborhood organizations, I try to ask them to liken this to the electric circuit in your house. I lived in an old house for a long time, and it was designed at a time when we didn't have a lot of gadgets. You had a TV, a radio, a washer and dryer maybe, and maybe a couple of kitchen appliances. When I moved into that house, I had no less than 3 computers, all of the, recording stuff, this was back with tape decks and VCRs and all of that stuff. So I had like a dozen minimally a dozen things. And I was constantly tripping the circuit breaker and having to flip it, and I finally broke down and got some electrical work done. What happens to a child's brain when they're exposed to trauma is essentially the circuit breaker trips constantly. They're in a constant state of hypervigilance around the next assault on them. And so their brains are washed in all of those stress hormones that we know and hate, and they never get a break. And that impacts the wiring, literally, in their brains. And so you have some kid whose brain now literally doesn't function because it's exhausted. Parts of it are dead. This is the old commercial, this is your brain on drugs. This is your brain after trauma. Same concept. Next slide. So how did we get from thinking about the science around this stuff to moving people into thinking about changing their practice? Next slide. I started with a dream. I'm from Memphis, so you know I have a dream. And my dream was, when I moved back to Memphis in 2003, it was before this whole system of care. Anybody heard about system of care? Children with mental illness and their families and supporting them and all of that. There's a whole federal movement around that. And my community applied for and received in 2008 a system of care grant. They named it Just Care Family Network and proceeded to drive it into the ground. Poor management and administration, lots of people thinking they were going to get the millions of dollars that were seeded into this community. It was for 6 years, $9 million, the goal being to establish capacity in the community to support kids with mental illness and their families using the wraparound approach. Wraparound is not a treatment, it is not a service, it's an approach, because it's theoretically the way you introduce family support, resiliency, and family-driven, youth-guided services into a population. So anyone who says wraparound service for you, don't laugh at them, but you'll know they don't know anything about wraparound. If they don't say wraparound approach, they're leading you around the mulberry bush. So that was what we were supposed to be doing. I was not employed by this group. I had moved back to town to take care of my mother, and I was kind of just hanging out. I was trying to retire before I hit 40 years out of med school. But friends of mine who knew I had worked in all of these places that you heard earlier said, you got to give your community some of that skill, some of that knowledge. So I agreed to come on board as a community volunteer for a governance meeting. I went to one meeting, got elected chair. After I heard some of the stuff, the crazy stuff that was going on, I started talking and writing in meetings, and wound up being asked, when they relieved the director, asked to serve as the interim director, which I agreed to because they were going to search for a permanent director. And the families decided that they didn't want anybody else, they wanted me. And so I wound up taking the job in 2011. When we still had 3 years left of work. We were on what the government calls terms and conditions. They were about to take the money back because we had done such a poor job of implementing the grant. And we turned that grant around in about 18 months and wound up getting 3 awards at the end of our grant period. We wound up getting an extension on the grant, and we used the extension money to do some other things that I'll talk about in a minute. But it was based on a system of accountability, flexibility in the use of funding, being youth-guided and family-driven, which meant that at the core of all of the governance, planning, implementation, design, and program development were kids and the families that we worked with. They had to be represented on each of our groups. One of them co-chaired with the community person, the governance council, kind of a board of directors, if you will, for the grant. And it really worked well, which was, looking back on it, became the foundation for what I'm doing today. Because this is what allowed me to convince the community that we could handle this problem, that we could deal with this. And there were enough people from diverse parts of the community present and working on this that I got to see the broad scope of who was willing to put in the hard work and who I could come back to and say, well, if you were willing to do that, would you be willing to do this? And there were quite a few people in this group. We had formal evaluations. If you want to look at system of care evaluations, just search for Children's Mental Health Initiative, CMHI. There is a required report, I believe, every 2 years to Congress to reallocate monies for this program that's been in place since the 70s. So you've got lots and lots of evaluations. Ours is probably in the aggregate somewhere in there. But here's the kind of stuff that came out generally. Caregivers in our system became more satisfied with the child's behavior and with the family's interaction. There was improved school performance, fewer interactions with law enforcement, and a reduction in expressed mental health symptoms. Next slide. So this was the foundation. And then, because we had been so successful with this, we applied for, with the state, a Samson MacArthur grant to look at diversion policies and programs for justice-involved youth with those behavioral health disorders. That's 65 to 70% of undiagnosed. We decided we needed to take a look in our own backyard at what was going on. So the next slide gives you a glimpse at what we found out. We looked at 4 months worth of data. We put together a mental health assessment tool. We used it for every child who was referred to our, what we call evaluation and referral unit at the court. And under referrals from the court are the numbers totaling 65 over that 4-month period. And the number of referrals was 2/3 of those who were referred. 2/3 of them got referred for further mental health evaluation and treatment. So our numbers were pretty consistent with the national numbers. And this was a couple years ago. Next slide. And so now we've got 2 things that we've done well. I've organized a wraparound program and gotten people to buy into that. We've demonstrated that locally we've got some issues that are similar to the national issues, and we go on a PR media blitz. We take everything we can find anywhere in anybody's journal or newsletter or paper, and we start putting it out in the community. And I am on every local news, entertainment, those morning show things talking about juvenile justice, mentioning things like ACEs and trauma-informed care, and why are we calling them juveniles, and things like that. And so we pepper the community with information. This is a very important component of doing this kind of work. Once you get people all geeked up about we can do something, then you got to get everybody else, because you got a nice little core group of workers. Then you got to get the media and all the other people engaged in this, and this gets the attention of legislators and policymakers, because they like being on those shows to talk about. I heard one person after we had done this whole blitz get on the Live at 9 show and start talking about ACEs, and I thought, I've never heard anyone talk about ACEs. And he was spouting all the stuff we had given out at our little meeting. So obviously he had read the material, and he was demonstrating to his constituents that he knew what their needs were, and he was willing to back it. Worked for me. I don't really care how they come to the well. I just want them drinking the water. Next slide. This is a representation. I couldn't find the one we did for the juvenile justice system. This is a representation of something called sequential intercept mapping, SIM. It's a very evidence-based practice of strategic planning around providing mental health, behavioral health services in criminal justice systems. This is kind of a representation. And basically what it does is says there are 5 points within the continuum from the engagement in the community with law enforcement to the release back to the community. There are 5 points where a significant impact can be made for people with mental illness. And if you look at those 5 points and you think, well, at the point that law enforcement first approaches you, when you're thinking of kids, what's happening in the community when a law enforcement officer approaches a kid? Typically, they're doing something that's pissing off law enforcement. I mean, beyond the breaking, carjacking, and gun charges, they're walking when they don't want them to walk somewhere. They're hanging out in a crowd bigger than they think they can manage if things get out of control. They're talking back. They're acting guilty in some way. They're, disrespecting someone. Those are the kinds of things that kids do normally, because developmentally that's where they are without their brains. But those are the kinds of things that kids do that get the attention of law enforcement. So if you approach at the beginning, how does law enforcement play into this, and what can we do to help law enforcement not react in certain ways that escalate behaviors in kids that result in them being detained, not, since kids are not incarcerated, they're detained. I love euphemisms. So there are things we can do there, working with our law enforcement partners. There are things we do at the initial, for those who do get detained, at that initial detention court process. There are things we can do for kids with mental illness and behavioral disorders who are in fact detained. There's really, in my mind, no formal juvenile reentry process. There are times when I will use the word juvenile as it refers to a system, but not to the individual. So at the reentry point and the community corrections point, we're still a little lagging in the area of what we do with kids. But this is kind of the concept of how we think, my center, thinks about where we can make an impact. Next slide. This is the group, when I had my juvenile justice sequential intercept map, this is the group that I gathered. That's a lot of people. We also did the adult system, but over half of these people came there specifically to participate in the juvenile justice sim. These are people that represent, anybody here in the Rotary? No? I'm a Rotarian. I would never have dreamed of being in the Rotary, but our local Rotary took up as their cause reducing juvenile crime by 50% in 5 years. Once they took it on, I became part of them because now they're part of my team. They're part of the stakeholder group. So I'm a Rotarian and can go on Tuesdays at noon to lunch just about anywhere in the world and have a lunch and say, hi, I believe in the 4 principles and all of that. But we've got schools, juvenile court, county government. This guy here is the deputy chief of the sheriff's office. This is our juvenile court judge. This is the Rotarian in presence, our public defender, corrections director. I mean, just represented throughout this. The mayor was there for a part of the day, but I don't see him on this picture. Next slide. So here's just a little something for those who don't know anything about ACEs. This is why ACEs matters in the health arena. If you score more than 4 on the 10-question ACEs questionnaire, these are the statistics demonstrated scientifically and studied well and longitudinally. These are the statistics around health, general health issues that we have found. Next slide. And the whole area of ACEs is fascinating, so I would encourage you, if you don't know it. Shelby County, where Memphis is seated, did its own ACEs study, and here are the numbers. Most people had no ACEs. 20% had at least 1, 21% had at least 2 or 3, and a whopping 12% of the population studied scored 4 or more, which is kind of standard nationally at this point. Most people don't have high ACEs. Most people have low to no ACEs, but the critical mass of people who do have 4 or more ACEs take up the lion's share of the funding and services in the health, mental health, substance abuse, social services, and public health areas. Next slide. So, what's an academic community partnership actually look like and do? Next. Oh, I think this slide may be out of order because this talks about, these kids. These are the kids that are difficult to quiet down, that have regular outbursts, whose parents talk about not being able to control them, who are always blaming others for what's going on, who see the world as threatening and judgmental and blaming. Next. Okay, here we go. Here's an example of intervention policy development and training to impact the health status of justice-involved youth. Let's take the topic of ACEs or childhood trauma, for example. Okay. What we did in terms of the intervention was keeping with intervention policy development and training. We did a massive trauma training. We trained everybody and anybody from the lady on the corner who knows everybody's business in the community, to doctors in the hospital, to ministers, to teachers, anybody we could gather more than 3 or 4 at a time. We would provide a trauma 101 training, introduce the topic, make sure they understood why it was important to know about it, and get them experienced in thinking, how does this affect me or mine? That was all we wanted to do. We started working with law enforcement and did some police training around that first interaction, step 1 on the, intercept 1 on the sequential intercept mapping, which we continue to do. And then we started talking, because we had some other grants in town, we started talking about why it was important in a city that was experiencing a lot of violent crime, that we started talking about the impact of violence, trauma, and ACEs on children. Police officers were reporting they would get to a very violent crime scene and find 2 or 3 kids huddled on the couch, you know, hugging each other and not know what to do. How were they supposed to interact? They waited for DCS to arrive, but if that took a while, they were just kind of there not knowing what to do. So we began helping them think of how to interact with children and removing them and those kinds of things. And then we looked for opportunities to collaborate between all of these people using general guidelines of it being culturally appropriate, where the community was engaged, and if at all possible, directing the initiative with some support from us, and that it was made to be accountable and measurable so that we were able to collect data all along the way. Next slide. So how did that look? We talked about the kinds of treatments that we could provide, and we trained people to these treatments so that we were building capacity. I had, through my Just Care grant, I had trained a couple of dozen mental health providers in trauma-focused cognitive behavioral therapy. I've now trained another half dozen or so in EMDR and purchased the equipment for them to use, because grants allow you to do that stuff. And I like to make good use of other people's money whenever possible. The policy, we established a basic policy of universal trauma screening for all kids in the justice system. So wherever they came into the system, with a couple of exceptions, because attorneys think that they're going to somehow admit to something and it's going to be used against them. But wherever we could, we got everybody involved in screening. Schools, juvenile court, DCS, everybody. We started talking about risk factors and then created policies around how do you meet those challenges of the risk factors and remove them as impediments. And then we went back to the training where consumers, communities, folks, community stakeholder groups, and everybody got these kinds of trainings, and always and foremost had an awareness of we have to spread this message beyond the people who are using the services. We've got to make this important to everybody. It's not just if you have a child in the system, it's because you are a part of this community that it's important. Next slide. There's a, for those who are interested, there's this reference, and I won't show you the article, but there's a thing called aces2high.com that you can go to, and a doctor wrote this article about the most important thing she didn't learn in medical school was about adverse childhood experiences. It would have made her a better doctor. And she was not a psychiatrist, she was I think family medicine. Next slide. And looking back, she thought how badly she had treated people with smoking, who smoked, who were drinkers, who had diabetes and chronic health problems. This is our mayor, who now is a trauma-focused maven. I guess men aren't mavens. Trauma-focused champion. This is a minister, this is the director of corrections, this is a DCS person, this is a community advocate, and our county mayor and myself at one of our big partner meetings. And this was just a group that was assembled. Next. Here's some of the outcomes that we got when we began looking at ways to provide trauma-informed care. Most importantly about this, I think, were while school and fewer arrests is important, we began seeing signs that we were working on, we were having some success in our work to improve physical and emotional health, and that we were logging fewer reports anyway of suicide attempts. Next. Caregivers, the important people in this equation. Caregivers said, I'm not getting called every day at work. That's a good thing. And if you're seeing families and moms are reporting every other day, twice a week I get a call from the school, then you're probably looking at someone who could benefit from a trauma evaluation. And that there was overall an improvement in family functioning after they got involved in a more trauma-informed approach to providing services. Yes, next slide. This is, and I'll just run through this. This is the screen version of the ACEs questionnaire. There are only 10 questions in 3 different domains: abuse, neglect, and environment, mental illness, somebody in jail, homeless, and that sort of thing. So next slide. And it is available on the internet for free in a PDF version for download. And once you add up all your yeses, you get your A score. And we generally don't do it in public settings because we want people to have access to someone to talk to. But it's important to know what the questions are and to work them into your general dialogue with a patient or a family member around what's going on that's bringing them in repeatedly. Next slide. Remember this if you remember nothing else about tonight. Risk factors are not predictive factors due to protective factors. I didn't coin the phrase, but I have adopted this as my personal professional mantra. If we only see the risk that kids have for winding up in the system, and we predict their future based on their having these risk factors, we don't take into account the fact that there are protective factors. We are the protective factors. Science tells us the #1 thing that helps any child on this trajectory is a caring, consistent adult presence in their life, unconditional, consistent, caring, there no matter what, kind of their ride or die adult, okay? Risk factors are not predictive factors due to protective factors. Next slide. This is part of that media blitz. This is the same picture, I think, that's on the flyer. But the university set out to do a whole promotional campaign to introduce the center, and the original ad people thought that it should be hammering away at juvenile justice or something. I said no, because then they'll think every kid is a nail. Let's think about the brain rewiring, that whole electrical circuitry thing, and they captured that, I thought, and someone then translated it for the Latino paper, our local Latino paper. I'd never seen it in Spanish. And a friend brought it to a meeting to show me that I was now in Spanish. Champion of troubled youth, guardian of the future. It sounds a little like Star Wars or something. Yeah, Wonder Woman or something. But it worked because this was on the local, Fortune magazine allowed the university to have a wrap around their regular paper for magazine for 4 months. So everywhere I went in town, there was this picture. I was told it was on the side of a bus. There's nothing scarier than seeing yourself 10 feet tall. Next slide. But it worked, it got attention. Here's a flyer from one of our big community meetings last year. At the end of one event that we hosted, we did trauma through the lens of culture and brought all of our stakeholders and community folk together to talk about trauma, culturally focused, culturally based, becoming a trauma-informed community. Next slide. This is one of our big meetings. This is actually the church of the woman that I pointed to earlier who's a minister. This is her fellowship hall where we host a fair number of meetings. It's a nice location. It hosts maybe 75 to 100 people, so we can have a big meeting there in a nice community setting and get outside of the academic arena. Next slide. Here's another gathering of our stakeholders at a corrections facility where we were invited to come and talk about trauma and family involvement. And there's the usual diverse group of people. There's somebody from business, somebody from the community, a few people from community corrections programs, the school system, and I forget some of the other folks. Next slide. This is in South Africa. I was invited to come to be part of a conference, and these two guys, this guy is one of the trauma researchers, and this is the chairman of the Department of Psychiatry at Boston Medical College, I think it is. But I was on the program to talk about trauma and ACEs globally with panelists from other parts of the world. So this is globally impactful stuff. Next slide, which I think should be the last slide. Yes, this is the last slide. So that's my center. That's how we kind of formulate ideas around doing the work. And I will tell you honestly in closing that it is the job of the director of a center like that to bring people together. That's my daily work. Every day that I'm there, I'm never in my office. I'm always somewhere in the community meeting a new group of stakeholders, making a new friend, creating new relationships. Just today, I was telling Consuelo before she came to get me, I got a call from the court about helping them find a way to keep a girl who has been detained for a few weeks from going into DCS custody when it appears she may actually have a psychotic disorder, that she's acting out in these ways, and there's no mechanism right now because of the charge that she has for them to get her evaluated. And so I'm calling stakeholder collaborative partners to see what we can work out. I have no direct ability to admit anyone to any one of these facilities, but I know people. Sometimes it's about making this stuff work. It's about knowing people and having relationships with people. So I would encourage all of you to make good relationships, to be good collaborative partners, and to think about long-term where you'd like to get to, and then lay the foundation for getting there. You see what we did. Each thing builds on something else, and keep growing your circle of collaborators, if you will. And they'll bring other people to the table for you sometimes. Thank you.